we notice pink everywhere. October rolls around and suddenly we notice pink everywhere and ribbons, clothes, signs as far as the eye can see. What is Pink October? Why do we see ribbons and color pink everywhere? October is a breast cancer awareness month and is an annual international health campaign organized by a major breast cancer charities every October to increase awareness of disease and to raise funds into its cause prevention, treatment, and cure. And the pink ribbon is the international symbol of breast cancer awareness. The wearers and the wearer express moral support to women with breast cancer. Pink for October. The breast cancer is the commonest female cancer in Sudan and worldwide. Our mission in Sudanese Society of Breast Imaging and all other Sudanese societies and campaigns is to continue on raising awareness of this disease, its signs and symptoms, early detection and diagnosis, and we should always give support and create hope for breast cancer patients. Remind them there are millions and millions of breast cancer survivors, and many people might survive for years and even decades. Life becomes beautiful with hope. Together we think how to fight against breast cancer. Learn more about breast cancer and early detection. And breast cancer awareness is an effort to raise awareness and reduce the stigma of breast cancer through education on symptoms and treatment. So our learning objectives of this talk is to discuss some background of breast cancer, describe measures of breast cancer preventions, awareness about roles of breast imaging in both screening and diagnosis of breast cancer, and to share information about breast cancer staging and management. This can be achieved by answering these questions about the breast cancer. What is the breast cancer, its incidence, its cause, symptom and signs, how diagnosed, and types, stages, and how we could prevent it. So what is breast cancer? Like other cancers in the body, some of the breast cells, it grows abnormally, out of control, very rapidly, more than the healthy ones, and this process can spread to the other organs. The incidence of breast cancer is it is the most prevalent malignancy among female populations worldwide, and in Sudan, representing 30% of invasive cancer in women. And in there is 1 in every 8 women will receive breast cancer diagnosis in their lifetime. You can see it here at the top of the list of women cancer, and also can be seen high in the list of cancer deaths. It is responsible for the second highest number of cancer-related deaths, both in developing and developed countries. Sorry. The breast is a modified skin organized gland that developed from the mammary ridge in intrauterine life. And this is the mammary ridge or mammary line extending from the axilla to the groin, which is involute lately, still within the intrauterine life, remaining only small portion over the chest wall where the future breast developed over the, which is extending up to the clavicles. It can extend up to the clavicles. It is usually between 2 to 6 ribs, but can extend up to the clavicles. Medially can extend to the sternum, and laterally to the mid-axillary lines, and up. Sometimes it extends into the axilla through the axillary tail of spines. And if a small part of this line not involute, can result in an ectopic breast like this one, or ectopic nipple. But this usually and most commonly seen in the axilla. So the breast composed of skin and breast parenchyma, which is formed of a gland embedded and supported by stroma. The gland consists of about 12 to 25 functional lobes. These lobes drain through the milk through ducts into that converge into the nipple. The breast is resting into the pectoralis muscles, and posterior to which is the chest wall. So the breast cancer types can be classified primarily according to its locations. And as we know, breast cancer is heterogeneous disease because it is not arising from a single cell types. If it arises from the ductal system, we call it ductal carcinoma, ductal breast cancers, which it can be in situ or invasive cancer, or if it arises from the lobule here, we call it as lobular carcinoma. And in case of infiltrations of the skin lymphatics, it can result in inflammatory condition like, which is rapidly progressive over days or even weeks, in days or weeks, that call inflammatory carcinoma. And the other entity of a cancer that arise within the squamous cells of the nipple, they call it a Paget disease or a mammary Paget disease. However, the more accepted theory is that arises within the duct and then migrating through the epithelial of the duct, which is known from the development of the breast. It's connected with the epithelial surface of the nipple skin. And the other types is which arising from the stroma of the breast. Phylloides tumor, fibroepithelial, arising from both stroma and the gland, while others arising from the stroma, they call it sarcomas, which are extremely rare, like angiosarcomas. Also, breast cancer can be divided according to the spread into ductal carcinoma in situ, invasive cancer, or metastatic breast carcinoma, and other types of breast that can be just seen under the microscope, having a characteristic appearance like medullary, papillary, tubular, and mucinous carcinoma. This is the microscopic anatomy of terminal duct lobular unit. And this is the lobule here. You can see the olfactory of the milk extending into the ducts. And the it is a bilayer, consists of luminal epithelial cells and a basal myoepithelial cells lined by a basement membrane. The significance of this, we can see it here. This is a normal cells, ductal cells, and here there is proliferation contained within these ductal cells with intact outer layers and basement membrane, and in this case, it labeled as ductal carcinoma in situ. When this infiltrate or proliferation of cells extend to the outer layer and breach the basement membrane, infiltrating into the adjacent structure, then they label it as invasive cancer. Okay, so what is the cause or what is the etiology of the breast cancer? As we mentioned, the breast cancer is a heterogeneous disease with no single characterized cause. However, there are many factors work together that influence or increase the chance for a woman to get or to develop a breast cancer, including environmental, lifestyle, genetic, hormonals, and others. A lady could have all the above listed factors or risk, but still might not get a breast cancer. So these risks can be divided into two categories: changeable risk, which can be avoided and result in prevention of breast cancer or reducing the chance to develop breast cancer by about 30%, while the second category is unchangeable risk, which cannot be avoided, or non-preventable risk factors. Let us start. Usually, we have to create hope. Start by the changeable or preventable risk factors. This to follow by following good lifestyle, we can reduce the chance of getting breast cancer, especially eating a healthy food and avoid the high fat saturated diets, red meat and added sugars. But in the other hand, we can consume more vitamin D rich food, green tea, fruits and vegetables, polyunsaturated fat, and soya. Definitely, avoidance of alcohol, it will reduce the risk, since it's a drinker considered to have about 30% increased risk of breast cancer. And adoption of exercise is an excellent prevention for breast cancer, for the chance of developing breast cancer, and recommended to have at least 4 hours per week. Obesity, especially for postmenopausal women, has to be avoided, and hormonal replacement therapy and contraceptive unless prescribed by the clinician, and there is need for that, and avoid smoking also to reduce the chance of developing breast cancer, and the light pollution and staying up late. They found that staying up late and those who are working at night, you see, and exposed to the light for the whole night, this stimulate melatonin secretions and increase hormone-related cancer like breast and prostate. And the chemical radiation exposure can also be avoided. As you know, urban residents have associated increased risk of breast cancer by increased air pollutions and carcinogens from industries and crowded traffics and this stuff. Okay, non-tangible risk. First of all, female gender. Being a female definitely is the main risk of breast cancer. How common is male breast cancer? You are lucky. It is 1 or even less than 1%. The age, breast cancer, like other cancer, increasing with advanced age, and presence of family history, especially premenopausal breast or ovarian cancer for first-degree relatives, is a high risk for breast cancer, and the gene mutations like BRCA and other syndromes. These are considered to be a high risk, however, are contributing only for 5 or 10% of breast cancer. And those who expose their breast during development between 10 and 30 years of old, exposed to chest or upper abdominal radiations, can also result in a high risk of developing breast cancer, as well as a personal history considered to be a moderate risk, but it can be a higher risk for breast cancer if the lady developed breast cancer or diagnosed with breast cancer below the age of 50. High-risk lesions. Some of the benign proliferative breast lesions considered to increase the risk for developing breast cancer, and the high density of the breast. Regarding the reproductive factors, early menarche onset and late menopausal, both are considered to be risk to or increased risk to develop breast cancer, because the lady, it will prolong the time for the lady to be exposed for the estrogen. For the same reason, the nulliparum and the first full-term pregnancy after the age of 30 will increase the chance of developing breast cancer. Okay. Non-preventable risk of breast cancer. Some lady or many ladies with breast cancer are asymptomatic. This can be, we can conclude that we could not control the chance of getting breast cancer. So what is the solution? Solution is early detections to get a chance to get rid and of small lesions, okay, and to have much better cure. As you know, prevention is better than cure, and most breast cancer cases are highly treatable, especially if caught in its early stage. How we can, before going for the preventive measures, let us first discuss what are the symptoms and signs of breast cancers. Palpable abnormality is the commonest cause for or commonest presentive signs of breast cancer. Usually, it is painless and non-mobile, but it can, in early stage, it can be mobile and not affected by menstrual cycles. Also, the same applied for a palpable abnormality in the axilla. Sometimes cancer breast can be presented by remarkable enlargement or change in the shape of the breast, that it can be distorted. However, we have to consider other causes of bilateral breast asymmetry, like using one breast more than the other in lactation, and some fluctuation during the menstruations. Changing the skin, it can be red, can be presenting with itching or rash, and increased warmth. Also can present with pitting edema in a form of the orange appearance, skin dimpling or puckering, and it can be a fungating mass with sores and ulcers. Breast nipple changes can represent breast cancer, either to be swollen nipple discharge, different colors, nipple retraction, and nipple scab, okay, as well as crust. But we have to be cautious, because all these can be seen in a benign condition as well as in cancer patients. Definitely, this case bilateral symmetrical slit-like variant, and here this crust, whitish crust, and especially if the patient lactating, it can represent just a milk. Okay, here this is illustration, summation of all these signs seen in a lemon, okay? And the importance for these signs and symptoms is if the woman experiencing new, severe, or persisting symptoms. Because we said that there is overlap between benign and malignant for all these symptoms. But if the symptoms is persisting, or if it is new, or if it is severe, then definitely she has to contact a healthcare provider. And in many cases, symptoms may go unnoticed until it becomes severe. We should also consider the symptoms and signs related to the metastatic disease, like when depend on the system that been involved. If it is respiratory, if it is lung involved, it will present by respiratory symptoms, cough, shortness of breath, or if involved the bone, might present with the back pain. And if it is in the abdomen, can be presenting with jaundice, nausea, vomiting, diarrhea, and constipations. And we should not forget the paraneoplastic syndrome as a presentation for breast cancer, which is a serious and a dangerous, life-threatening condition, and abrupt clinical management should be considered. Though it can be just presenting by general constitutional symptoms like fever, weight loss, decreased appetite, and sweat, or it can present by specific symptoms related to specific system in the body, like nervous system, skin, or endocrine, and so forth. Okay, what are the measures for the early detection of breast cancer? The self-examination, clinical examination, or screening, mammogram, and other breast imaging. Regarding the self-examinations, recommended to start at the age of 20, okay, and it's up to the age of 40 or 39. It's supposed to be 1 to 3 years, okay? No, sorry, I sorry for confusion. This is regarding the self-examination. Self-examination, it has to be started at the age of 20, and it should be regularly performed every month, okay? For premenopausal by the end of the period, and for postmenopausal just to fix 1 day each month, okay? Specific day one each month, and it is really simple. And the self-examination, it doesn't need other than just sofa to lie on and a mirror and the patient or the lady hand, nothing else, and her eyes to look at, okay? Nothing. And it is though they did not prove to be improve the incidence of cancer detection, but still recommended as a potential tool for screening mammography, for screening for breast cancer, especially if the lady be familiar with, if she's regularly doing it, she will be familiar with her breast. And if there is any change in the look or feel of her breast, then she has to contact a healthcare provider. Regarding the clinical breast examination, is an essential tool, especially in our country, because we have a lot of mammography machines, and it has to play an important role. And it has to, according to NCCN, recommended to start at the age of 25. and continue after they begin having mammogram screening. And between the age of 25 to 39, it has to be evaluated every 1 to 3 years. And after that, it should be annual. Okay. Reminders that 60 to 80% of breast lumps are benign. However, usually the concern of the patient and her physician is to exclude breast cancer. And definitely catching breast cancer early is crucial. Screening mammogram is the third tool in early detection of breast cancer and considered to be the most important one. And it is the cornerstone of population-based breast cancer. Can prove that can reduce breast cancer mortality by up to 40% or more in women aged 40 and above. And mammography can help to detect 85% of all breast cancer, often clinically occult. So what is mammography? Is a special breast X-ray exam with compression to recognize abnormality within the breast, either in a screening setting, as we mentioned, the patient will be asymptomatic patients or who have elevated risk or having whatever of these elevated risk, high risk or dense breast or personal history or all this stuff, or in a diagnostic setting if the patient having abnormality or proceeding to evaluating abnormality seen on a screening mammography, or patient having a follow-up of probably benign lesion, follow-up after biopsy, follow-up of cancer-treated patient, extent evaluation of extent of the disease, or in case of implant assessment. So mammogram performed by a technologist and reporting by a radiologist, and it can be performed in a mobile unit to surface the rural areas, or a mobile mammography bus in a case of a population-based breast cancer, but can also be performed for screening in the department, and the patient can be standing. If she could not stand, also can be performed in a sitting position, because the new machines can be moved up and down, and here also can be performed in a prone position or in a bending position, using the effect of the gravity to pull the breast away from the chest wall. Here you can see how mammography can be performed for the two standard view, the craniocaudal, and here this is for the MLO, and it is important the positioning and inclusion of even the axilla. Can you see in this case here our patient had disease in the axilla, and performing two the standard views, including two perpendicular views, because if we could not visualize abnormality in one view, it could be appreciated in the other one, as in this case. And sometimes we need to do additional views, as in this case here, faintly we can see, we can suggest, or we can suspect that there might be a calcifications, but when we did this spot magnification view, definitely we could appreciate the calcification and characterize it well. Mammography can also be performed for the male, and here this is a cancer in a male breast. And this is, and as you know, the mammography system is a special X-ray machine that developed exclusively for the breast and here you can see the first dedicated mammography system, a French one, introduced in 1965. And this, you can compare it with these modern machines. Okay, is the mammographic radiation carcinogenic? We have to weigh the things. The radiation dose used in mammography studies are considered safe. It is negligible. It is considered virtually non-existent. The amount of mammography radiation is equivalent to a natural background radiation levels over about 7 weeks. So experts consider it as a negligible risk is far outweighed by potential benefits of mammography, and that is why the Society of Breast Imaging, the American College of Radiology, and National Comprehensive Cancer Network recommend annual screening mammography beginning at the age of 40 for women at average risk of breast cancer. As you know, we are usually looking for smallest breast cancer, okay, to be detected, to improve the survival. And even stage 0 or the DCIS, the survival can approach 100%. How we can achieve this? Definitely with mammography. With the era of screening mammography, the palpable lesions have been replaced by the non-palpable breast lesions. This has a significant impact on cancer management. Here you can compare large cancer with this very tiny sub-centimeter cancer, and screening mammography definitely is a non-invasive method and our best way to screen cancer. Can you see here the magnification? Even this cancer could not be appreciated on the standard view, but well seen here as asymmetry with malignant calcification or suspicious calcification on the spot magnifications compression view. Another examples of sub-centimeter, very tiny, like rice. You see a piece of rice lesions, and because of background fatty breast, definitely you can pick smallest sub-centimeter lesions. And they found that screening mammogram detect about 75% of cancer at least a year before it can be felt or it can be palpable. And in other literature, they mentioned that mammography precedes the clinically detected cancer by about 2 to 3 years because it allows appreciation of subtle difference among soft tissue densities. So as you know, to be this cancer to be palpable, it might need to reach about 1 to 2, 1.5 to 2. But the cancer detected by mammography can be even 3 millimeters. Again, look here, this is the first round, very faint, tiny lesions progress in the second round, but still it is sub-centimeter. So getting regular screening test is the most reliable way to find breast cancer early. And studies have shown that regular screening mammography decrease the risk of late stage cancer in women 80 years of age or older. Another example, to compare large cancer, palpable cancer, to just very tiny sub-centimeter non-palpable cancer. So early detection of breast cancer by mammography is the key for successful treatment. As you know, And screening mammography greatly improve women's chance for successful treatment because it allows the diagnosis of a smaller tumor with fewer nodal metastases, less histologic grade, and grade progression that make treatment more effective. So the decline in advanced stage disease afforded by mammography screening is directly related to substantial decline in breast cancer mortality. Okay. When reading mammography, we have to consider embryology, physiology, and anatomy. If you look for this mammography, it looks the same, but the shape, it looks the same, but different in density. This is the same mammography. This is the same lady having mammography at her age of 30, which is extremely dense, but at 55, her due to reduction in female hormone, definitely the breast density become less. And considering the embryology and development of the breast, we could understand why the appearance of this nipple is inverted or slit-like in both sides. And this is compared to this everted nipple, and we can differentiate it from these pathological nipple retractions. While reading mammography, we have to put this in our mind. The gross anatomy of the breast has to be in our mind while reporting mammography or any breast imaging. And if you look here, definitely this is an abnormal mammography corresponding to this appearance of BD orange. Why? When we go back to the illustration of gross anatomy, you can see these lines which represent the infrastructure of the breast, the Cooper ligaments supporting the breast, traversing the breast tissue from the skin back to the pectoralis muscles. When get infiltrated by the tumor, okay, or edema, it become here because it is infiltrated by the tumor, getting irregularly thickened or non-uniformly thick. These lines have haphazard lines representing these Cooper ligament and buckling the skin, resulting in this appearance orange-like or beady orange appearance. Here you can compare the abnormal mammography or edematous breast, and you can see how nice, smooth lines, thin lines, or thin opaque lines, linear densities representing these Cooper ligaments. Okay, the ACR developed a system or a lexicon giving certain descriptors for the mammographic abnormality, and especially those who representing the breast cancer, which include a mass, asymmetry, microcalcifications, architectural distortion, nipple changes, skin thickening, trabecular thickening, and axillary adenopathy. Have a look at these images, please. Okay? We'll discuss it later. We'll talk about it. Here, all these patients, the cancer seen at the region of the axilla. Okay. Can you see the variations in cases? Okay. These are about 100 cases, half of the breast cancer patients coming last year, 2022, in Soba University Hospital. Okay. Look for the variations. Here, different patients. Each mammographic image represents single patient or different single patient. Okay, and here, can you see this? Look like an circumscribed mass, but on a spot magnification, we said spot compression magnification view sometimes is important. Demonstrate that it is a non-circumscribed and its extension into the nipple areolar complex. Also, these lesions here, it seemed to be just an asymmetry, but on a spot compression demonstrates that there is indistinct irregular mass. And the same for this one. It was very small, very tiny, well appreciated on a spot compression view. And this is fungating mass before she removes the gauze, filling the site of the ulcers. But can you see how big the ulcer, well appreciated after removal of the gauze? And this case, these two cases, also from those 100 patients, demonstrate how mammography helpful in the evaluation of post-neonatal follow-up of chemotherapy, neoadjuvant chemotherapy treatment. But definitely it's helpful because it is a fatty breast. And this patient presenting with a residual disease after operations 1 month ago or 1 month back for a breast cancer. Also fortunate, it was a fatty breast, so cancer was easy to. But here, this is a dilemma. Usually, this is the area or this population where mammography is so much challenging, where the patient having scarring in their breast. If you look here, some they have a wide local excision, and the others even having mastectomy. But in spite all these representing a case of breast cancer recurrence presenting at that time. And this is a male breast. These are 3 male breasts presenting there. These mammogram are gynecomastia, while this having a gynecomastia on the left, but on the right side, this is a breast cancer in a male breast. And what about this? This is an MRI for one of those patients, you see, demonstrating the extension of the disease from one side to the other across the midline. So, and the recent literature support the use of breast MRI for a woman who have a recent diagnosis of breast cancer, because MRI is useful in identifying the disease extent of the cancer. And I will say, especially for Sudanese women, because of this new phenomena. Okay, so we have some comments on the breast cancer in Sudan. We notice that relatively more women with from northern Sudan, and we observe more advanced breast cancer at diagnosis, a lot of bilateral disease, study in progress, also observe a lot of cases of lobular carcinoma, which is also suggested that may have a strong hereditary component and might explain the more bilateral disease, unexpected lymphangiectatic spread, as we present the previous case, across the midline, also might affect or might contribute to higher incidence of bilaterality. And we believe that Sudanese women have cancer in younger age group. And I supervised 2 theses just finished a few days ago. In these studies, we found that in one study, the number of patients were about 120, something like that, and the younger than 40 was seen in 17%, while in the other study, the breast cancer, the number of patients was about 500, and the cancer patients were about slightly a bit more than 200. We found almost 30% of breast cancer younger than the age of 40, which is not concordant with the international incidence. We notice a large number of cases of young age ovarian cancer. And as you know, it is known that higher than average risk women tend to have tumors at younger age, larger and more biologically aggressive lesions, more node positive tumor at diagnosis, and higher interval cancer rates. And the hereditary breast cancer in general has variable imaging appearance and can range from an aggressive appearance to mimic of a benign entity across all breast imaging. So, our Sudanese women have a higher incidence of familial or hereditary breast cancer? Does the race and ethnic disparity play a major role in the Sudanese female breast cancer? As you know, that breast cancer in some races is more aggressive. There are even more questions can be raised about breast cancer in Sudan that can be answered by various research studies. Together, we think. We believe in the power of early detection, knowledge, and community support in the battle against breast cancer. But the celebration of Pink October should not be limited to community awareness lectures or symposium only. And it should not be limited to the month of the October. It should extend throughout the year. And from this opportunity, I will love to pass an invitation from the Sudanese Society of Breast Imaging to all of you to work together fighting against breast cancer in our beloved countries. Take actions. Yes, we need to do bulk of research to understand more about the disease in our country. But still we need dedicated center for diagnosis and treatment. We need machines. We need good number of dedicated technologists, well-trained dedicated technologists. We need more and more expert radiologists in breast imaging. We need genetic counseling. We should consider earlier and intensive screening programs. Continue working together as a collaborative effort in all specialty, medical, and community societies that are concerned with breast cancer. Not only that, we have to build a strong committee in the Ministry of Health. So what I can say, we dream of decreasing the advanced breast cancer and shift to a lower stage of breast cancer at diagnosis in our beloved countries. Okay, let us go back to our lecture. We said we have to consider physiology and all this while reading mammography. Here we can see this same patient with different mammogram This before starting tamoxifen as a baseline, and this is after tamoxifen. Demonstrate a reduction in breast density, signify efficiency of the treatment, and which is associated with a lower risk of recurrent cancers. And this is what is called conventional ductography. You can inject, or we can inject, iodinated contrast media through a discharging, not a discharging duct or discharging opening in the nipple, okay, to delineate the ductal system. And this is here representing our patient, demonstrated the papilloma. You can compare it with this suspicious intraductal malignancy from the literature. And also mammography can be used as a guidance for stereotactic biopsy and wire localizations. Okay, can breast cancer be missed on mammography? Definitely the answer, it will be yes. There is certain false negative result, although mammography is a cost-effective and has proven to be a major and gold standard tools for screening mammography, but it is a structural imaging and its sensitivity is limited by breast density as well as textural complexity. The ferris can reduce the sensitivity to 50, and the textural complexity can even reduce it further to 60, by 60%. To only 60%, okay. So this is a nightmare for the radiologist, extremely dense breast, and more than that, this is textural complexity. This is a 2D. Can you see the cancer here in the 3D or tomosynthesis? Even on retrospect, it's difficult to be appreciated on the 2D mammogram. Not because of extremely dense, but because of textural complexity. Definitely in this background of black fat breast, you can see this white spot. But can you appreciate a white spot in the left breast, this dense fibroglandular parenchyma? It's difficult. Can you see it now? Even on retrospect, it's difficult to be appreciated. Like a comet in clear sky, definitely you can see it. Can you see it here in this cloudy sky? No. So the breast cancer is white and fibroglandular tissue is white. There is no contrast, but in a fatty breast, because of the contrast, you can appreciate it as smallest as possible. And that is why the sensitivity of the fatty breast or entirely fatty breast is the highest. The second is the scattered fibroglandular density, SER2, SER3 or C, heterogeneously dense, and SERD is extremely dense, like extensive cloud in the sky. Okay, if she's lucky, the moon, it will come up above the clouds like this, cancer arising at the apex of the parenchyma. Also, one of important factor influence the cancer missing is the technique. If you look here, you can see a developing asymmetry. You can see a spot, you can see a cancer here, and here you can see the years of screening mammography. Where is the cancer in the age of 2015 could not be appreciated. Why? Can you look for the pectoralis muscles appearance? Well shown here, but it is deficient here. It was contracted, pulling the breast in. That is why cancer could not be appreciated at that year. So that is why before starting reading mammography, we have to look and evaluate for the criteria and for the quality of the image of mammography. Another factors influence mammographic appearance is the type of the machines. This is definitely, if you compare the analog with the digital, the resolution is much difference, much improved in a digital mammography. So until recently, you see, you can see these types of film mammography. They are holding the glass looking at it. But digital mammography is rapidly replacing analog mammography and make life a little bit easier and replacing this type of glass by the electronic magnifying glass. Not only that, the full digital mammography has also options of a 3D or a tomosynthesis unit that further improve the accuracy and image quality of mammography. And recently, even there are system or guidance system for tomosynthesis biopsy. Okay, if you look here, you can see the analog image, digital 2D mammography, and tomosynthesis, how the image is improving while going toward to the left side. And can you see here how tomosynthesis improve detection of the cancer? Even on retrospect, it is difficult to see any abnormality corresponding to that area on the 2D. So the use of tomosynthesis improve cancer detection and also reduce the recall rate on a screening setting. Not only that, it's also greater, it has a greater accuracy in pointing the size in breast abnormality. You can compare this image, but still it has a limitations in extremely dense breast. This is a 2D and this is a tomosynthesis. Still the sensitivity is low in this type of image. The other new advances in the mammographic technique is the contrast enhanced digital mammography. You see, they are injecting iodinated contrast material intravenously and image the breast and can result in this type of image. See, this in the screening mammography, subtle area of architectural distortion, but the physiological image, the mammography here, it is only structural technique, but by giving a contrast, we convert it from only structural to structural plus functional. So we add a functional study, and that is why here we can see an enhancing mass at the site of this architectural distortion, improving cancer detections. Again, this is a 2D, 3D, delineate better this line, but in contrast study, we can see another lesion not appreciated neither in 2D or 3D. And the use of artificial intelligence also help in cancer detections and make and use as the second reading for radiologists to pick up any abnormalities that can be re-evaluated by the radiologist. If you look here, you can see on retrospect, we cannot see any abnormality in this mammography that can be appreciated in the computer-aided image. But it is seen here on ultrasound and how it is extensive on MRI. And we should not forget to fill the form of mammography, okay, because it is really essential. This is a type of these form, and we advise the clinician, please send for us all information regarding the patients, because it's going to help us in interpreting the mammography, including hormonal status, personal history, family history, all this stuff. It has to be sent in your request for the mammography. Is it only mammography, imaging the breast? No. The main three modalities are mammogram, ultrasound, and breast MRI. And the mammography definitely is the gold standard and the first chair in the orchestra of breast imaging, but the second chair in this orchestra is high resolution ultrasound. And with the mammography represent the conventional modality for breast imaging, and ultrasound, it is really important, playing important role in evaluation of breast disease and condition and in cancer detections, but most of the time in the diagnostic setting. However, recently has been playing an increasing important role in the early cancer detection and increasing in the and in screening setting. You see, and combined with mammography, improve the accuracy of conventional imaging and cancer detection. And they found that screening ultrasound may depict a small lesion, 10 millimeter, nodal negative breast cancer, not seen on mammography. And its sensitivity is higher in a dense breast and those under the 50 years of age and in a high risk group. But its limitation is that it has a high false positive rates, see, and the lower positive predictive value. So it will result in short-term, a high rate of short-term follow-up and adding more unnecessarily bulk. And it's also the time-consuming, and still there is no data on mortality reduction using screening mammography. But, as you know, also, this is highly operator dependent. The handheld ultrasound is highly operator dependent. If you look, this is the same lesion seen by one operator, and then more expert one demonstrate that lesion as more suspicious. Okay, what is this? What we have seen here, this is a handheld ultrasound, and this is automated whole breast ultrasound, which is developed specifically to help in small cancer, to help in detection of small cancer hidden in a dense breast. So it is used mainly in screening setting. Okay. As on mammography, when doing ultrasound, we have to remember the gross anatomy of the breast. Fatty breast, extremely sensitive on mammography. It is reverse on ultrasound, present the minimum sensitivity. Can you see this image? The lady presenting with a palpable abnormality. Here, the palpable abnormality is not due to these lesions because it is small and deep. That was the palpable abnormality, smaller fibrous ridge. But luckily, we could appreciate this sub-centimeter cancer, but it was difficult. Why? Because it is more or less near to the adjacent fat lobule in echogenicity. That is why fatty breast is difficult and its sensitivity is less on ultrasound. Ultrasound, can you see here, this mass, even on retrospect, difficult to be appreciated in this dense mammography. So it is more accurate than mammography in symptomatic women less than 45 years of old and can detect up to 40% of mammographically occult cancer. Again, this is, can you see here, this not much appreciable mass, how it is well characterized and well impressed of cancer on ultrasound. Again, this is a palpable abnormality here seen as subtle architectural distortion. Look at it, how it is ugly, speculated mass representing by rad at least 4-3 or 5. And again, look how it characterizes. You can see oval mass here and not very impressive of being cancer. But can you see the same mass on ultrasound, how it characterize and demonstrate ductal branching and this, and so it is irregular. It is bar at 5 on ultrasound. This is our patients. You see, and again, a water density mass on mammography can be seen on ultrasound as cyst, complex cystic solid, or can be seen as a soft tissue mass. Cancer rarely or in small percent can present as a cyst. So any complex cyst, that it should be reported as by RAD4 and recommend biopsy. You can see here irregular outlines or irregular margins. We call it non-circumscribed margin with the presence of nodule, make it suspicious. And this, the use of Doppler is also helpful in ultrasound, because here we can say this can be a complicated cyst. It might be an abscess because the outlines is not sharp, can be just an abscess. But using Doppler, it clarifies that this mass is a soft tissue mass, is not just a complicated cyst or a complex cyst or whatever. It is a soft tissue in a case proven to be infiltrative ductal carcinoma, and usually these types seen with most aggressive high-grade tumors. This ultrasound demonstrates a galactoceles, typical characters. And if you look here from the first glance, you might say that this is a circumscribed mass. It might be fibroadenoma, it might be phylloides, but when you sweep throughout the margin, can you see the invasion here of the adjacent parenchyma in a 38-year-old lady having invasive ductal carcinoma? And this one, it is only 18-year-old. This one from the literature. Can you look here? Definitely in 18-year-old, putting your probe like that and looking at it from the first inspection or from the first glance, you can say this fibroadenoma. She's 18 and this appearance fibroid. But while sweeping through the mass, can you see here the microlobulation, and can you see here branching pattern? This one, and it was proven invasive ductal carcinoma at this age. This our patient here, we can see the tumor extending into a dilated subcutaneous lymphatic vessels. As you know, ultrasound is the best modality and gold standard for evaluation of the axillary lymph node. If you compare it with the mammography, definitely here is not impressive, but this is highly suspicious axillary lymph node, another highly suspicious axillary lymph node, and by RAD5 breast lesions. Advances in ultrasound technology improve the accuracy of ultrasound. Can you see this isoechoic lesions improve with harmonic, and this elastography is also help in specificity of ultrasound and characterization of the lesion. This is just a simple cyst, while this is borderline lesions after elastography increase the level of suspicion, and it was a cancer. There is also advances by using contrast agent on ultrasounds and result in this type of, this is a grayscale and this is a post-contrast, like other post-contrast studies, improve the accuracy, also having the same as MRI, the curve. And here you can see these types of benign, and this is a malignant lesions. Ultrasound, as you know, it is easy. It is easy to be used. It is available. It is comfortable for the physician and for the patients, and that's why, and for many other reasons, it is the first modality used as a guidance for percutaneous imaging, biopsy, and interventional procedures, except for the microcalcifications, where mammography is superior to mammographic guidance biopsy is superior to ultrasound. Going to MRI, this example of dense breast in a high-risk patient with gene mutations, even on retrospect, we could not see any abnormality. Can you see here on MRI this 4 centimeter focal abnormal enhancement due to high-grade DCIS could not be appreciated on mammography. But in a higher than average risk woman, usually young and having a dense breast, mammography, this is limit the mammography, and the MRI definitely has a higher sensitivity than mammography, which is 90.8 versus 40%. Mammography is 40 and MRI is 90%. And this group or this population, as we mentioned before, is really challenging on mammography. Those who have personal history and who have previous breast scar. So it is really challenging unless we have the previous and we compare with, it will be really difficult to tell if these changes are due to post-therapy changes or due to scar carcinoma. And in this group, in this population, the mammographic sensitivity ranging from 0 to 53, while the MRI sensitivity is 80 to 100%. So to improve access to breast MRI screening and the demand for that, they abbreviated the protocol of the MRI to just pre and single post-contrast image, okay, as you have seen here. And as on other breast imaging, we have always considered the anatomy while interpreting, and it's also important to fill the breast MRI questionnaires before doing the study, okay? It will help in interpretation of the MRI. These our patients, 54-year-old, having breast pain. She was my neighbor. I did for her mammography. She has just subtle architectural distortion. Also on ultrasound, there is just a distortion. But MRI demonstrate extensive, okay, DCIS in her medial, lower medial breast. You see, proven pathologically, and raise a suspicion in the contralateral breast, which after 3 months, proven to be another DCIS, high-grade DCIS in the contralateral disease. So recent studies demonstrate that sensitivity of MRI is 68 to 96%, and its specificity is 81 to 96.8%. This is another patient showing how MRI is sensitive in conventional imaging occult cancer, presenting with this large axillary adenopathy infiltrating the adjacent structure in the axilla, but could not appreciate any mammography or ultrasound findings, and the cancer was appreciated on MRI. And this is from the literature. You can see asymmetry between the two breasts. Otherwise, there are very subtle features here in the right breast, might represent something in the right breast, but by doing MRI, it is clearly obvious that the right breast is shrinkage breast associated with underlying malignancy due to lobular carcinoma, invasive lobular carcinoma. And in this case here, you can see a highly suspicious axillary lymph node, but we could not appreciate significant abnormality or suspicious finding on mammography. This is from the literature, but doing MRI, this is the suspicious lymph node you have seen here. It can demonstrate cancer, small cancer in the retroareolar, because it is in the rich, lymphatic rich, though it is really small, it seemed to be sub-centimeter or just 1 centimeter, but presenting with axillary adenopathy because it is in the predictive locations. And this lady, you see, with architectural distortion and ultrasound demonstrate the suspicious mass, but MRI demonstrate the disease extent, and here extending down to the nipple areolar complex, which is seen to be involved. MRI depict DCIS component of invasive breast cancer in 95.1% compared to 3.2% at conventional images. Can you see here the extent of the disease? How it well appreciated, demonstrated, differentiate between a focal disease, multicentric, and multifocal disease. And here we can see, you see, this is a rotor node, interpectoral node, an internal mammary node, could not be appreciated on mammography or ultrasound, rarely might be appreciated on ultrasound, but on mammography, you cannot see it. And this lesion projecting over the pectoralis, it is 2D structures, structural images, the 2D mammography. We don't know if pectoralis has been involved or not, but by doing cross-sectional images, the MRI here demonstrates the mass far away from the pectoralis is not involved. Compare it with these two examples, demonstrate chest wall involvement, really very nicely seen, appreciated on MRI. And this is a case demonstrate the skin involvement along with this case. This is our patient here. We can see the infiltrations of the nipple areolar complex and the skin on the left side, and there is another cancer in the contralateral breast, well appreciated on MRI. MRI is superior to the conventional imaging in evaluation of residual disease in case of neoadjuvant chemotherapy. Can you see here? And especially for complete radiological resolutions. And it is sometimes concordant to complete pathological resolutions. It's also MRI superior in evaluation of residual disease, and it is reported to be up to 70% after excisional biopsy. These three examples demonstrate a seroma cavity with irregular asymmetric nodular enhancement in a case of residual disease. By evaluating all these details, definitely it will help the surgeon to decide if he is going to do lumpectomy or wide local excision or mastectomy. And even for the type of mastectomy, if it is modified, radical mastectomy, skin sparing, nipple sparing, or whatever, you need to know all these details, which can only be appreciated based on MRI. And also MRI is helpful in case of patient having an implant prosthesis. Can you see here very subtle findings on mammography, but when you look for the MRI, how the cancer is well appreciated. This case here, this my patients, the first, this one on the left side, she has a reconstruction with the prosthesis post-mastectomy, synthetic implant. We can see abnormal enhancement here, but that was just due to silicone leak. There was no cancer. But these patients having a palpable abnormality, we found that she had a suspicious finding proven to be cancer. Also, MRI is helpful in demonstrating the autologous myocutaneous flap, as shown in this case here. You see, this is the muscles coming from the back, or even the rectus flap or abdominal rectus flap, or all these type of flap. We have to be familiar with it. And if there is any evidence of recurrence, it will be appreciated. MRI, also breast MRI have facility to guide interventions. CT. There is a new advanced technique, you see, imaging modality to evaluate the breast using the CT. The patient lying like on MRI prone, can you see the hole here? The breast pendulous within this hole, and it is more comfortable for the patients with the same radiation of the mammography, and with it has a similarity to breast MRI. We can do reconstructions, but we are familiar with the usual CT performed for systemic evaluations, chest, abdomen, and pelvis, and also we can use it for local evaluation apart from the systemic evaluation. This ultrasound demonstrates the lesion abutting the rib here, but if we have no facility for MRI, or we could not do MRI, we can use even the CT to see if this lesion involves the chest wall or not. You can see the mass here. You see, we can trace it, the branching pattern to the nipple areolar complex is being involved if you compare it by the contralateral one. And we trace this branching extension into the chest wall with this intercostal muscle enhanced and thicker compared to the others, signifies that chest wall is involved in this case. And when hybrid with PET scan, the CT improves the accuracy for cancer detections. Can you see this here? You see, this is the PET scan demonstrate that this intramammary lymph node is highly suggestive of malignancy, along with or in addition to the axillary lymph node and the primary in the right breast. Here demonstrate the extension of the axillary involvement. And these are examples of inflammatory cancer in the PET scan demonstrated both on MRI and PET. And this here, huge mass infiltrating the left breast with intramammary lymph node. And interestingly here, this ultrasound demonstrates the mass. We could not see the posterior aspect of the mass due to extensive shadowing, but here definitely we could see it, that the posteriorly it goes deep and infiltrating the pectoralis muscles. But if we compare these two images, this is a PET scan for the whole body, okay? But what is this? It has the same, it demonstrates this lesion, but even demonstrate the extent of that lesion more. And again, this lesion is seen here, but we can see another satellite lesion or lymph node or another lesion seen here. So what is this? What is the difference between this and that? Both are positron emission tomography, but this performed for the whole body, and this one is dedicated for the breast. The same as that CT, you can see the patient lying prone with pendulous breast inside that hole, or can be performed like this. This is what is called positron emission tomography. This is again an emission mammography. They call it mammography because it is for the breast, demonstrate this hyper active lesions will not be appreciated in this extremely dense breast. And here it demonstrates how it is comparable with MRI. This is the BEM and this is the MRI. Can you see the ring enhancement and how the same lesions hyperactivity seen as the rim with a nodule, and that is a nodule, and this is the other lesion seen also here. There are many others breast imaging, but all of these are not yet appropriate for screening and not approved by the not approved for screening. It's okay. So who should get screening? We have three variants: high risk, intermediate risk, and moderate risk. The high risk, those who have those with calculated lifetime risk more than 20% or having genetic mutations, the BRCA are more recognized along with other syndromes, those with a strong family history or chest radiations during the developing time between 10 to 30 years of age. For those, MRI usually appropriate, and the intermediate group, those who have lifetime risk between 15 to 20%, including high-risk lesions. The high-risk lesions like atypical ductal carcinoma, atypical lobular carcinoma, and lobular carcinoma in situ also include personal history and high breast density, and here MRI may be appropriate, but for the average risk, those who have a lifetime less than 15%, only for annual screening, and MRI is not usually appropriate. So for whom we have to do mammographic screening and bilateral MRI, it is recommended, as we mentioned, for high-risk group. Again, those between the age of 10 and 30 who had radiation to their breasts from the chest or the upper abdomen. They receive a cumulative dose more than 10 gray. So they have to be screened by MRI and by mammography. And genetic mutations, specifically or especially BRCA1 or BRCA2, and those who have a strong family history, first degree relative. And it is recommended to start testing at age of 25. And they start for them MRI at the age of 25 to 30, and mammography can be started at the age of 40, can be delayed. Again, for the intermediate risk, the lady who, a woman who had diagnosed or who is diagnosed with breast cancer at the age below 50, she's eligible for both MRI and mammography screening. And those who have lobular carcinoma in situ, also they benefit from MRI screening along with mammography with or without tomosynthesis. But those who have atypia, atypical ductal hyperplasia or atypical lobular hyperplasia, for them we have to do tomosynthesis along mammography plus or minus tomosynthesis. But if they have other risk factors like dense breast or so, then they will be eligible for breast MRI. So we know that the recommendation for breast MRI for high-risk group, okay, started, and for the personal history, especially younger than 50-year-old, starting at the diagnosis, and for the personal history, if at any age, if associated with other risk, and for those who have dense breasts, okay, and desire supplemental screening, they can do for them MRI. And for women with atypia or lobular carcinoma in situ, this group, they can recommend MRI along with mammography. And for the recommendation of ultrasound, it's usually performed for those who at any risk group or elevated risk group having a dense breast, or those who have elevated risk and eligible or cannot go eligible for MRI, but they cannot do it, then can be replaced by ultrasound. And the same recommendation of ultrasound is for the contrast mammography, but molecular imaging should not be performed, is not recommended. Here we can see a BRCA mutation woman having this small group, two small group, proven to be high-grade ductal carcinoma in situ, presenting on MRI here. And this is a male patient having BRCA2, presenting with bilateral breast cancer. The left one is a palpable mass, but at the same time, they discovered very faint calcification here, even on the spot magnification view, could not well be appreciated, but well shown here in the specimen radiograph, and it was proven bilateral invasive cancer. This lady having infiltrative cancer here on her left breast, and when doing the CT for systemic staging, demonstrate this diffuse gastric thickening. What do you think the cause of that? Any suggestion?
Metastasis, maybe.
Metastasis. Okay. What else? Okay. If I tell you this is a lobular carcinoma, they found that the left breast involved by lobular carcinoma. So, what is the relation now? She had left breast lobular carcinoma, and they found the incidental findings of this diffuse gastric thickening. Any suggestion? Okay. Invasive lobular carcinoma is highly associated with hereditary diffuse gastric cancer woman with CDH1 mutation. One of the syndromes, one of the mutation, gene mutations, you see, associations. This is a personal history, example of personal history in 72-year-old lady had a history of treated dry breast cancer. Her screening mammography demonstrates these two tiny masses, well appreciated on tomosynthesis, and could be seen on ultrasound here, and biopsy result it was a cancer. These two tiny, it was 6 millimeter and 4 millimeter. Okay, as we mentioned that extremely dense breast or a dense breast is also considered a moderate risk, is one of the intermediate risk of breast cancer and is an indication for MRI evaluations. Can you see this mammography? You cannot appreciate any abnormality even on retrospect. Can you see the cancer on MRI for the same lesion here? And we said before, MRI has the higher sensitivity than mammography, ultrasound, or combination of both in this type of dense breast. Its sensitivity is 90 compared with 40% of mammography. Regarding the benign lesions, why now the benign breast lesions getting more attention than before? Because the more use of molecular pathology, okay, make interest in these types of benign breast lesions. Now they have more attention and they are looking for these types to exclude their association with malignancy, and to determine these potential risk of progression to malignancy. You see, and the more complex the benign disease, the higher the risk of progression to cancer. And that is why, because now there is a potential for prevention of cancer by giving a woman an options of chemo prevention or prophylactic mastectomy. Okay. So for MRI, should not jump directly and doing MRI before doing mammography or ultrasound. And we should not even interpret MRI without looking at conventional imaging, mammography or ultrasound. The reporting based on the ACR lexicons, the BIRAT system, and there are 7 categories, 0 to 6. 0, incomplete. It needs additional imaging evaluation. 1, negative study. 2, benign. 3, probably benign. 4 is suspicious. 5 is highly suggestive of malignancy. And 6 is non-malignancy. And this is here the standard reported format. Usually, we report based on this format, and this definitely improves the communications between radiologists and clinicians. So how we select appropriate breast imaging modality? Before we select this modality or we discuss the factors, we have to know that the 3 modalities are complementary. And in some cases, or most of the time, we need to do the 3 modalities, the 3 main modalities. Mammography, ultrasound, and MRI to reach a diagnosis or a conclusion. However, the age, symptoms, patient conditions play an important role in influence the selections, as well as availability of the image technique and the cost of the image technique, as well as the experience of the available radiologist. All these factors play an important role in selections of technique. And in this image here, definitely you can see this big or large surgical opening compared to this tiny non-invasive dot in a case of image-guided biopsy. And at the same moment, sensitivity is almost 97 to 99%. So now excisional biopsy is being replaced by ME-guided percutaneous biopsy and ultrasound-guided breast biopsy false negative rate ranging from 0.0 to 2.5%. So what is strategy of breast lesion imaging? We have to start with mammography, then going for sonography, and then to MRI if indicated, and always we have to consider the clinical. Always we have to consider the clinical and combine all the three modalities into single or one final BI-RAD category, which is the most suspicious outcome, and give management recommendation accordingly. What about these outcomes? There are 4 outcomes when doing mammogram and ultrasound, either mammography positive, ultrasound negative, both are positive, mammography negative, ultrasound positive, or both are negative. And in case of positive ultrasound, as we mentioned before, it can pick up to 40% of mammographically occult malignancy, especially in a dense breast. But when we have both negative studies, the negative predictive value, it ranged from 96.5 to 100%. So still we have 1 to 2% probability of cancer presence could not be appreciated on imaging. And as you know, that biopsy is the only definitive way to exclude cancer or to diagnose cancer. And if there is clinical suspicions, on clinical based biopsy should be performed. But if the clinical suspicion is low, then the case can be followed by clinical with or without imaging. So regarding the radiologic histologic correlations, we have outcomes also, either concordant malignancy. In this case, both radiology and pathology are malignant appearance, but we can have a discordant malignancy. In this case, pathology result was malignancy, but for us, it doesn't look malignant. Or concordant benign, radiology with pathology both looks benign. Discordant benign, they said it is benign, but for us, it is malignant. And borderline high-risk lesions result like lobular neoplasia, rectal scar, papillary, atypical hyperplasia, and so forth. So that is why in these cases, and it occurs many times during the practice of breast imaging and patient management. So it is important to be discussed in multidisciplinary meetings. And so also we have the pathology results, and the story for the radiologist, it should not be ending by just putting a report and sending to the pathologist. The result of pathology, it should be re-evaluated by the radiologist and look at it if it is concordant or discordant. And what is his opinion after that? Either to re-biopsy or to accept it or to follow that patient, or what is next in the patient management. We have to contribute on that, okay? And even we consider if the pathology benign, is it a definite benign like fibroadenoma, papilloma, or so forth, or non-specific like fibrocystic hyperplasia, duct hyperplasia, stromal fibrosis, and these non-specifics. Also, in these cases, follow-up is essential. However, there is no test or group of tests that can ensure that a woman does not have breast cancer. Okay. The breast cancer or benign lesion require triple assessment, and the clinical limitation in the diagnosis of early breast, there is clinical limitation in early cancer detection. Despite improvement in technology, still we have radiological challenges in some cases. Breast cancer is heterogeneous, complex, serious disease. Modern cancer management has become increasingly complex and specialized. That is why clinical practice guidelines recommend multidisciplinary approach, a multidisciplinary approach to breast cancer care, and should which is a collaborative effort of breast surgeon, radiologist, pathologist, and all specialties in breast healthcare professions. And definitely this will improve patient management. The AGCC extradition staging system of breast cancer include clinical staging, pathological staging, both therapy staging, and re-staging. And the information needed for the patient management and prognosis of breast cancer include in the clinical staging, which is pre-treatment or pre-surgical, complete surgical treatment is based on clinical history and examination, diagnostic imaging, and core biopsy and FNA before treatment. And we need to know tumor size, tumor type, grade, and receptors, the degree of penetration, the tumor is spread within the breast, skin chest wall invasion, focal, multifocal, multicentric, spread to the axillary lymph node, spread to other regional lymph node, spread to the distant organs. And in pathological staging, which based on surgical specimen, including the sentinel lymph node biopsy, we need to know the tumor type, the tumor nuclear grade, which demonstrate the aggressiveness of the cancer from low, moderate, or high grade. We need to know the biomarker status, genomic panels, steroid receptors, ERBR status, and HER2 status, and Ki65, and so forth. Okay, so the anatomical staging TNM of system of breast cancer include T4 tumor, lymph nodes, and metastases. And regarding the tumor, it is either in situ, TIS. If it is 2 centimeter or less, it is T1. Between 2 and 5 centimeter, it will be T2. More than 5 centimeter, T3. And T4, any size that can extend to the adjacent structures. If it is not involved the nodes, it will be N0. If the node involved but limited movable lymph node, it will be N1. If it is in ipsilateral axilla involved but fixed, then it will be or the internal memory, it will be N2. If it is metastasized to the other lymph node, regional lymph nodes, it will be N3. And if no metastasis, it will be M1. If there is distant metastasis, it will be M1. Okay. Wall, as seen in these illustrations, here it will be T4A. If infiltrate the adjacent skin, then it will be T4B, representing by ulcers, nodule, or edema of the skin, including the orange appearance, then it will be 4B. If both just wall and the skin are involved, then it will be 4C. And if in case of inflammatory carcinoma, it will be T4D. So summation of above categories can result in the clinical staging, in the following clinical staging. Stage 0, the early disease, DCIS, no invasive cancer. From stage 1, start the invasive cancer, but when the tumor is 2 centimeters or less and no lymph node involvement, then it will be stage 1. And if from T0 to T3, okay, and N0 to N1, but no metastasis, then it will be stage 2 and also consider an early disease. Stage 4 is the locally, stage 3 is locally advanced disease. It's also invasive cancer, and there are 3 types of stage 3 and stage 4, any of the above, okay, with metastasis. Any tumor, any lymph node status, but there is metastasis. Since there is metastasis, it will be stage 4. So stage 3, it can be A, B, or C. It depends on the which tumor size or the involvement of the lymph node. Looking for the lymph node in one, as we mentioned, that movable ipsilateral node. When this node become fixed, it will be N2. When the node involve the internal mammary, but the axilla not involved, it will be N2. If both involved, axilla or internal mammary, it will be N3B. If level 3 involved, it will be N3A. If supraclav involved, then it will be N3C. Okay, let us go back to our society, Blood Society. This is Dr. Medina, the president of the Sudanese Society for Breast Imaging, together with Pink. What is the Sudanese Breast Imaging Society? Is the Sudanese Society of Breast Imaging is a voluntary charitable organization. It is an association emanating from the Sudanese Society of Radiologists, which deals with breast radiology. We aspire to actively contribute to early detection of breast cancer through continuous training in the field of breast imaging, and with an effective contribution to raising awareness, spreading the culture of early detection, and the correction of wrong beliefs among the community, hoping to improve survives in this, to improve services in this field. It is based in Sudan, Khartoum State, with the generous hosting from the Radiology Department, Khartoum Teaching Hospital. We aspire to extend and establish branches in all states of Sudan. And the objectives of the society is scientific courses and practical training in the field of breast imaging, help in findings, chances for qualifications and training for the radiologists interested in the field, improve the service in the field by establishing a specific breast imaging units, including diagnosis and sampling within the radiology department of the capital hospitals, and then in all regions. Improving the services provided for the patients, participation in setting local guidelines for the prognosis, for the diagnosis and the management of Sudanese breast cancer patients, and involvement in the patient management, encouraging and spreading the idea of joint clinic, the MDT, and build and maximize awareness on digital media. Our way of actions is cooperation with government agencies and other voluntary associations, including outside and inside, that are working against breast cancer, and participation in local, regional, and international conferences related to breast diseases, active participation in the International Breast Cancer Awareness Month, conducting training courses in breast radiology, lectures and workshops for both the doctors and technologists, initiating free health days and clinics, seminar and exhibition. Okay, nobody fight alone. Here you can see these beautiful faces last year in screening clinics. You see, this one of the achievement of the society. And here, this is the contribution in workshops. The same last year, 2022, October, and that was a symposium. And here you can see these faces raising awareness on digital media, radio and TV. So, Ignite Pink. At the end, we can summarize the recommendations of the ACR 2023, just this year. They recommend that all women, especially Black and those of Jewish descent, they have to do risk assessment by the age of 25. And genetic mutation carriers, untested first degree relatives, they have to have annual digital mammography plus or minus tomosynthesis at the age of 40. If annual MRI started at the age of 30. And annual MRI has to be started at the age of 25 to 30. Calculated lifetime risk of 20% or more, so it's still high risk. They have to, they recommend for them annual mammography plus or minus tomosynthesis and annual MRI started at the age of 30. History of chest or abdominal radiation treatment at young age, we said between 10 and 30. They recommend for them annual mammography and along with or supplemented with annual MRI. And the age, at the age of 25, this should be beginning at the age of 25 or 8 years after treatment, whichever is later. And if the patient exposed for radiation at certain age, you can calculate 8 years and then start the screening. If she exposed at the age of 23, for example, or 25, then no need to start screening at 25. You will start after 8 years. Personal history of breast cancer less than the age of 40. Then at the time of the diagnosis, they have to be to begin annual screening mammography plus or minus tomosynthesis, as well as annual MRI. If dense breast or if diagnosed less than 50 years. Others with family history consider MRI from the age at diagnosis. Okay. History of atypical or atypia, ductal or lobular, and lobular carcinoma in situ, diagnosed before the age of 40. Then at the time of diagnosis, you have to start for them annual mammography and with or without tomosynthesis. And consider annual MRI if other risk. They said it is the benefit, the lobular carcinoma in situ benefit from the MRI. For the atypia, if there is other risk, dense breast or other risk, they recommend to start for them breast MRI. Dense breast tissue. In case of dense breast tissue, recommend for them annual annual mammography plus or minus tomosynthesis and annual MRI, and consider annual contrast mammography or ultrasound as alternative to MRI. It is time to schedule your mammography to save your life. رسالتنا إليك اليوم حبيبتي، ما عايزة تكشفي، خايفة إنك تكوني مصابة، بنقول لك اطمني. الكشف المبكر هو أهم استراتيجيات الوقاية الثانوية، والهدف هو تشخيص مبكر. وبنقول لك نسبة الشفاء من سرطان الثدي ارتفعت في الآونة الأخيرة بعد تطور استراتيجية العلاج وانتشار الوعي عند النساء بأهمية الكشف المبكر عن سرطان الثدي إلى أكثر من 95% في حال اكتشاف المرض في مراحله الأولية. وبنقول لك كمان يا ستي المفاهيم الخاطئة اللي بتقول الخزعة بتنقل المرض. الخزعة لا تؤدي إلى انتشار المرض، ولا بد منها لتشخيص نوع السرطان، ومن غيرها لا يمكن تحديد العلاج. وبنقول لك قبل الألم والشعور بالندم تعالي أفحصي واشكري النعم. تعالي أفحصي، أبعدي القلق والألم النفسي، اطمني، عيشي حياتك وانتعشي. عشان تتخلصي من المرض ما تنتظري ظهور العرض، سارعي، احجزي للماموجرام، احمي نفسك وافحصي الآن لتنعمي بالأمان قبل لا يفوت الأوان. Thank you very much.
Thank you very much دكتور رباب. يعني المحاضرة جميلة جدا و very interesting و takes through البروسيس من البداية، من الهيستوري والامبريولوجي وكل throughout the entire process. شكرا جزيلا لكم. إذا في زول من الأودينس عنده سؤال.
في سؤال؟ طبعا هي إما كله مفهوم يا إما كله ما مفهوم.
Thank you so
لما
much,
ما يكون
boss,
في
for the
سؤال مش كده؟
informative lecture.
نورس؟
Thank you so much. It was such an amazing lecture, very informative, up to the point, وأتمنى الجميع يكون استفاد منها.
شكرا جزيلا. طيب